it's a small enough group that I think just ask questions as I go, rather than me give you a monologue for an hour and have everybody nod off. I just prefer that more interactive style. And so I'm going to just talk about really focusing on health disparities, how that impacts cardiovascular disease, and some solutions to the health disparities problem. And just wanted to give a little introduction. Everybody probably knows this, but blood pressure is one of the key ways to save lives. Very small percentages in blood pressure will drop your stroke, MI, and heart failure by 20 to 50%, depending on which one. For us, this is very important, as it should be for everyone. Huge public health issue. And when you start to look at all of the interventions you can do in a population, blood pressure control is probably the easiest and most effective one. That and colon cancer screening are my two big passions. Stroke mortality, it's a continuous curve with blood pressure. Higher the blood pressure, higher the age, higher the stroke risk. And so you want to pay a lot of attention to this. Same for ischemic heart disease. And not going to go into a lot of detail other than there's not a sharp cutoff at 140, even though HEDIS says there is, or 150 now if you're older. But it is a continuous function, but it's somewhere along the line you have to make some decision points. I certainly can.
So we have this new guideline that
Yeah.
says that we're going to change the very controversial part of the new JMCA is that they're moving the number to 150 for
Right.
people over 60. So looking at your data, I do not really understand.
This is actually not my data, it's Lancet's data. But
Looking at your data, looking at the very
Right.
powerful data there, why does that make sense?
I think in part is the issue that there's competing mortality. So people die of other things. As you put older people on blood pressure medicines, you start to get into issues of fainting, hip fractures, other stuff. So I know here we're focused on cardiovascular disease, and if your goal in life was to eliminate cardiovascular disease, you might be more aggressive, but that's part of the reason. And then there's the issue, this is your blood pressure. It doesn't necessarily mean in individual patients lowering it will impact mortality. That's a different study, if you follow what I'm getting at.
So at what point on the low end of blood pressure for older people do you start seeing the falling in the family?
No cutoff point there. We get nervous when there's systolics below 110. We actually just published some data, and I think it may only, I don't remember if it was just renal disease or all things, but your blood pressure curve is actually following a U-shaped curve, and if you get too low, your mortality also goes up. Not reflected in the Lancet data.
As we're spending a lot of effort now on the frail patients because 5% of the population is not, but a lot of those people are in the mid-80s and higher with high systolic blood pressure. There was some papers about a year and a half ago out of Scandinavia that they actually did better. Leave them alone. I don't know where you feel on that. And again, I'm not even sure we talk about pseudo hypertension in the elderly. We really couldn't measure an active pressure. I don't know where you measure that.
So I'm not a hypertension expert. I'll clarify that. Regardless, you're absolutely correct. As people get older, the literature tends to, nobody does a study on a bunch of 85-year-olds and controls their blood pressure. The drug companies don't find that a lucrative market. And so there's a paucity of literature as you get higher and higher in your age range. And so we tend to not focus on those folks over 80. We don't measure their results or their control rates after a certain age. I believe it's 80 where we cut it off. For the reasons you said, you can sometimes do more harm than good lower is not always better. So, I wanted to sort of address this issue that I think comes up a lot. It does in our medical group. Everybody thinks their patients are sicker, poorer, less literate, less compliant, have more comorbidities. And that's, I think, the one universal constant amongst physician groups. They don't seem to understand the concept of averages, and half the people are going to be above average and half below, but it's an interesting phenomenon. Has everyone run into this issue? And so the real issue is, how do you lead through this? And I think the main thing is to recognize there's hard patients and there's easy patients. On average, only 50% of the doctors will have sicker, more difficult patients to manage. It's not 100%. But for those that do have that, I think the key is really to approach it in a systematic fashion and not pretend, but you actually have to, as a leader, I think, set an expectation that any kind of disparity based on race, ethnicity, income, etc., is not acceptable. And I'll talk a little bit more about that. Here's a list of health disparities. You know, the common ones you run into are race, age, socioeconomic status, language preference, big in Southern California. Roughly 10% of our patients prefer to speak Spanish. It's a huge, I assume some people probably have a higher percentage. It's a problem, but it's also an opportunity. I think the message is this is sort of verboten. We need to get rid of all of these disparities. If you look at the IOM report, they consider equitable care a key piece of quality. It tends to not be measured. And I guess there's a lot of reasons why we have disparities, and this is what I want to sort of get into. Some of it's within the health system, some of it's outside the health system, and then there's this big gray zone in between. There's bias, both conscious and unconscious bias. So some people, there's been really interesting studies, even people of the same ethnic group as some of the disadvantaged groups will treat their own folks differently and have their own stereotypes. So it's not necessarily having a matching of the various racial ethnic groups is not necessarily even going to solve the unconscious bias issue. It's fascinating stuff. A little bit of data. The VA studied this really well. They're a great hospital system, and they found a fair amount of disparities here in hypertension, A1C, LDL. And I actually speak admiringly of the VA that they're willing to publish this stuff and address it and take it on. And these rates are actually, if you think about a doctor in a panel, they're not massive. Yeah, at a population level, a 5% difference in blood pressure control is a ton of MIs, strokes, etc. But when you're talking to an individual doctor in his practice, and if he has 20% more African Americans in his panel, it shouldn't affect his control rate that much if he's as good as the VA. Are these rates higher outside of the VA? Possibly. It actually impacts care, so amputation rates, and it's really kind of funny, because so amputation rates, blacks have a higher amputation rate than Caucasians, but when you factor in zip code, and you'd think wealthier would mitigate that, and it actually makes it worse. So there's a lot of interesting nonlinearities and interactive terms in a lot of the disparities work here. And that was sort of the point. It probably has to do with African Americans in wealthier zip codes have more vascular surgeons and can get more stuff done to them. At least that's the theory. So this is what I was talking about. Intrinsic factors, I mean intrinsic to the healthcare system. That's what we all work in. There's a whole society outside of us that consists of society where patients spend 99.99% of their time and only 20 minutes appointments with us. And then there's this overlap zone where It's not clear. Is this a societal problem or is this a healthcare systems problem? And I'll give you some examples of that. But this to me is the interesting zone. Is if you go into European countries, they'll spend a lot less on healthcare, but a lot more on social workers, social support systems, etc. Are they smarter than us or not? That depends on your value judgment. But the point being, you need to look at the whole patient to really address most of these cardiovascular issues or lifestyle issues impacted by all sorts of things outside of the strict control of the healthcare delivery system. So, how are we going to reduce disparities in cardiovascular disease? There's really three approaches. First is to create highly reliable systems. And I think in this room we've talked about creating various titration algorithms. That's a portion of a system. If you follow a titration protocol, everyone gets the same protocol. And so if you're from a lower socioeconomic group or a different ethnic group, you'll still get the same type of care, assuming you can afford it.
Have there been studies that have shown that? Like systems that have?
I will show you that. But I mean, and actually, people are it's not clear out of these three. This is my definition here. Either you create reliable systems, so if you have unconscious bias or even conscious bias, the system will override you. And if everyone who needs LDL level gets a letter regardless of race and ethnicity, you'll have less disparity than if you leave it up to the subjective nature of people with all of their variation. The other is to provide culturally responsive care, harder to define, harder to measure, but it can be, and then address the social determinants of health. Do people have adequate food, housing, etc.? These to me are the way I look at it. Some of these are external to the healthcare delivery system, although where one draws the boundary on addressing social determinants of health is not totally clear. Maybe people have other classification systems. I'm going to talk about highly reliable systems because that's sort of my thing and passion. And I have a background actually in systems engineering and know more about that than the nuances of hypertension control. But bottom line is when you start looking at disparities, you just got to start somewhere and draw a line in the sand and say we're going to look at this disparity and try and address it in some kind of way. And you know, you sort of look at the magnitude, how big is the disparity, what's the clinical importance, do you think you can fix the thing? Those are the three things we look at and determining which ones we're going to take on. Do we really know what we're doing? No. We've had some really good success with hypertension, and I'll show you some of that data. We've been trying to reduce the flu vaccination disparity in African Americans, a lot tougher, but we haven't given up yet. You got to measure this stuff, and that's a key. We know when we don't measure things, we don't improve. Systems and just culture are key, and this isn't a political thing. As you start to address this in your own systems, we at least found all of a sudden the Tea Partiers and the ultra-liberals come out and they all have their stuff, and in fact this is just medical care and good quality, and that stuff needs to kind of stay in the political arena. At least that's my view on the thing. Current data, clear algorithms, and I think we're going to show you some of our hypertension algorithms. Prioritize things, and a lot of this is just basic quality improvement stuff. Multidisciplinary teams with accountability, and we'll talk about some of these things. So I'm going to talk about systems. First of all, what happens when you don't have systems? Let me talk about leadership a bit. I talked about most patients thinking their patients are harder. You got to set the same standards, and you can have more compassion for the doctor that has sicker patients. You can feel sorry for him or her. Maybe even give them a little more resources, but I don't think you should say we're going to lower the bar. So as an example, everyone familiar with the NCQA diabetic recognition program? It's something physicians can submit their data to on their diabetics. If they meet certain quality thresholds, they get a recognition from NCQA saying that they're really good at diabetes, and you couldn't display that publicly in your office, and we have it on our internet site. We started this about 8 years ago, and I got huge blowback from all of our doctors that said, well, I have too many Latino patients, and they're harder to control, and they don't speak English, and this isn't fair that we should have to get this same recognition. We actually put money on this, not a huge amount, but enough to pique people's interest. And huge blowback. At the time when we started, only about 20% of our doctors were getting the award, and I was under pressure to make some kind of adjustment, did not. Right now we've got 1,600 physicians getting this award. Essentially everybody gets it who has a panel in our system. It's worked out really well. It's a good motivator for physicians to actually see their progress, and I'll talk a little bit more about CME and MOCs, but this gets recognized by at least the Family Medicine Board. So lack of systems. What happens when you don't have systems? This is what typically happens. Doctors finish residency, they join a practice. There is no real, first of all, who practices? I mean, does any other profession practice? You go get on an airplane and the pilot says, oh, I'm practicing my flying today. I don't know how we get away with that, but we do. But the hypothesis is really not having a system allows unreliable care that increases disparities. And I think that's true. I can't prove it in a randomized trial. Why is this? We all know there's too much data floating around there, a lot of literature data. If you look at medical records, you've got patients with massive records and charts, and most doctors, I think I'm being generous when I talk about them operating at a 2 or 3 sigma level. It's probably 1 sigma, huge number of mistakes. We all see it. And so you got to have backup systems. Just relying on people to be diligent and work hard is not a good thing here. So when you start to get into your records, everybody knows they don't share data. Everyone documents differently. And it's hard to actually share information, which makes it hard to create a system, but it can be done. So if anyone wants to look at a good system we think is good, read the Joint Commission Journal from 2013. It'll describe a lot of what I'm going to talk about. And part of my spiel here will be, doesn't really matter if you're treating cardiovascular disease, cancer, vaccinations, whatever it is. Once you set up the system, you can do everything at once. And so the idea that you're going to focus on Hattie may get mad at me a little bit here, but the idea of focusing on cardiovascular disease, I think, misses some of the opportunity. If you focus on putting in good systems, you can plug any single disease in there, even if it's not cardiac, and you'll get good results.
So Michael, the
yes.
idea was there.
Yeah.
Let's start with something that's fairly simple and straightforward.
Right.
Like you said, blood pressure is going to have an outsized impact if you get that right.
Right.
It's fairly straightforward. If we can get the systems working and understanding they can really make a difference with something fairly
Right.
straightforward, they might be able to.
So this is a chicken and egg thing we're having here. And I think, I'll go through a little bit of the history on how we approach this thing, but my point is, whether you focus on hypertension or focus on putting in systems, at the end stage should look the same. I think you do both at once. What we were able to do is actually improve our average HEDIS score about 2 to 3 times the national average over a 10-year period. So it was a sustained intervention, sustained improvement over 58 or so HEDIS measures. Many of them cardiovascular, but all of them went up in a similar order of magnitude. Have a large number of these above the 90th percentile. I attribute it mostly to this system we put in place. I want to talk about variation. Systems remove variation. We study variation. If you look at hypertension control in a group of doctors, some people have higher control rates, others lower. if you actually study the magnitude of that variation, you can learn how reliable is your system. So as we started our work, we'd see much larger standard deviations amongst the hypertension control rates. If we go to better facilities with better systems, the standard deviation drops. And I had a slide of that which didn't get into my deck. We call it the variation report. And the idea is don't just look at the average control rate, look at the spread. If you're seeing a lot of variation, it means either you have a bad system in place or you have some physicians underperforming and increasing that standard deviation. You can't tell just by looking at this, but we find that you have some of our offices where very tight distribution, some very wide distribution, yet their averages are about the same. And to me, that's an opportunity anytime you see variation. If you just look at the averages, you miss all that. So, key take home, I think. This is our complete care model, and this is what Hattie's getting at. We started out with diseases, and we focused, I think diabetes, where's diabetes here? Right here. Is one disease, and we started working on it, and we added in COPD, and hypertension's in there, and every time we worked on a disease, we found we had the same infrastructure in place. And so we were duplicating ourselves, and we had hypertension people working on that, and then the diabetic case managers did that, and we had separate CKD folks. And in reality, when you flip this thing on its side, regardless of any disease you're working on, there's certain functions that you can do that will address any disease whatsoever. We just started one on Down syndrome, believe it or not. We just plug it into this thing and it goes. It's not quite that easy, but.
Before you move on, can you just say a little bit about each?
Yes.
Like sure that we don't know.
That's what I am going to do. And the idea here is, I think if you think about it this way, you'll find if you can, let's just talk the first one, preventative and lifestyle change. You don't want to have your hypertension folks set up a whole program on that that doesn't include your diabetics and your CKDs and all of that. So, yeah.
I wonder if I frame it differently and say, and I just wonder if you agree with the hypothesis. If you look at the data on people 45 or older or 65 or older, the number of them who only have one chronic condition, diabetes, is like 5%. But about 60% have 3 or more. 30% are saying 4,
Right.
and 40% are 5 plus. So why would you ever set something up that was specific to a diagnosis when that diagnosis is associated with 4 other diagnoses?
You wouldn't, except that we do.
No, I
And that's sort of my point. I mean, part of it is, yeah, patients have 3 or 4 diseases at once. And part of it is, what was driving me nuts is, if you go back to this slide, I had 20 different disease programs and I couldn't keep them all in my head. It was just too complicated. So you're spot on with that. People don't just have one disease. And that's what my doctors tell me. They all have 50 diseases and they've never seen anyone with isolated hypertension in their practice.
3%.
I wish our diabetic prevalence is, I wish it was 5%. I think we're pushing north of 8 or so.
No.
But you're right.
Every diagnosis.
Oh, only diabetes?
Great,
Yeah.
You haven't seen it that's described by age, all Medicare beneficiaries, and how many chronic conditions they have. And of all the conditions you have listed there, no more than 8 or 9% have just that
Right.
condition.
So the point being, you can control a lot of cardiovascular disease by having weight management programs. Whether you outsource them to Weight Watchers or you do it internally, or we have health ed programs that do this. You'll treat like a whole pile of stuff with weight management. It's not publicly reported, it's not measured, but we all know you lose weight, your blood pressure goes down, your cardiovascular risks go down, etc. Same thing with physical activity. We actually have something called exercise as a vital sign, where we measure how much people exercise per week with a target of 150 minutes per week. It is sad to say how many people are sedentary, but roughly a third of our members say they get 0 exercise per week. So we've got a bunch of couch potatoes as members, but I suspect that that's the normal population. Yeah, Jennifer.
So what Dr. Kanter been able to do is these questions are asked every single visit. You go in, you're asked every time you go in to get a visit, how much alcohol do you drink a week? Do you have any discussing, do you have domestic violence? So all these things are taken every time. And if you answer yes to them, you do a triage. So it's really amazing that those preventive lifestyle learn every visit, every time.
Yeah, so one of the things like with weight, osteoarthritis, I mean, a whole bunch of non-cardiac stuff enters into this. So it's every doctor, every visit. It's not every visit. They pushed back. We started it that way, and now we have a time interval, like every 6 months the question pops up. But the point is to have a system to capture all of this data and to be able to know who's doing it, who's not, and have some sense of where your population is. And we don't talk a lot about smoking in these things, but to me this is key. I thought we were doing really well. Our smoking prevalence is a little under 10%, until somebody pointed out that means you got about 250,000 smokers as Kaiser members, and that picture of 250,000 bothered me. Point being is you can set up programs, even alcohol abuse can impact blood pressure, etc. So it's something that should be systematically screened for during your visits, and I'll tell you how we do that in a minute. When we talk about a proactive encounter, that really has to do with what Jennifer's talking about. There's 3 components. What we do in the encounter, and the other 2 are what we do in between encounters. So I will talk about that. I hope the slide was just misordered here. We have health education, key for literacy. About 10% of our diabetics attend a diabetic education class every 2 years. I'm trying to get that number higher. We have
Isn't that low because they don't want to?
Good question. It's low because people actually don't like the term class. I know I'm in a school here, I shouldn't say that, but some of it's branding, some of it is it's time commitment for the patient to say, I'm going to go to a diabetic thing. It's like hour sessions. I think there's 6 of them. So it's a big time commitment. People get busy. I don't know. It's a good question. I'd like to see it higher. Oh, they're after me here. Hopefully they'll get smart. And let me shut this off. So I think it's important, if you don't set up your own education programs, to at least have some place to send people. There are community resources for these kinds of activities as well. And we have our own weight loss programs. We have wellness coaches that people can call a phone line. Once it's set up, it doesn't matter what disease they're calling about. Guidelines relate to the ability to generate practice guidelines, titration algorithms, all of that stuff. And we'll show you some of it for hypertension. But once you have a unit set up that does guideline development, you're good for any disease, even if your infrastructure was such that you just knew which public guidelines to go to and grab from American Heart Association or whatever. You should have some, I think, functionality to do this. If you're smaller, you're going to get more external guidelines. But as long as you have something to use, and we give CME to our doctors. Everyone's familiar with MOCs? Okay. No, MOCs is maintenance of certification. This is actually a key system that everybody should know about. Physicians in the good old days just got their board certification and went on their merry way. Then they just had to go to continuing education classes. Now they have to actually do a performance improvement project and show that to their boards to get recertified. So this is a huge tool we use to actually motivate physicians to improve their cardiovascular disease performance. That diabetic recognition program I talked about is honored by American Board of Family Medicine. There's a heart stroke program that NCQA has that also counts as MOC credit. But if you want physicians to do performance improvement, that's the carrot, I think. If they have to set up their own projects, which they do, it is a huge time sink for them. If you can create some system that sets up a standardized and performance improvement program for many doctors, they will like you. Seriously, it's very popular, and it's helped us move our cardiovascular care in a positive direction just by creating that alignment. It's different than a financial incentive, which people can kind of ignore or get cynical over. They need this MOC credit to keep their boards. So, outreach is pretty straightforward about sending people reminders and letters. Doesn't matter what there's actually an art to it. We're getting very complicated between Twitter, online, texting, all of this stuff. There's a real expertise that if you start with one disease and get those folks outreaching your hypertension patients, and then have to do something with diabetes, you're going to replicate a lot of infrastructure. We do about 10 million touches a year in our system. So these are the components. SureNet is actually not related to cardiovascular disease, so unless Hattie wants to know about it, I'm going to skip through that in the interest of time. But it's really a safety net designed to catch medical errors that happen. We're actually working on people overlooking hyponatremia, which is often due to diuretics. I guess there is a little.
I do want to know, is that where the Dorn and the Milk Plan project
No, it could, but you know, we have actually health education. If you want to, and there's one thing we're looking at with strokes. So we have a health education department. Stroke patients have a stroke at home, and then they dawdle around, and they don't come in until their 3 hours are up, and then you're like frustrated. So this is something that can be taught in a health education program. We do teach signs and symptoms of strokes and what to do based on prior right care meeting. That was we're in Berkeley. We're looking into working with Stanford on actually doing simulation training for high-risk patients. So rather than just tell them, here's the signs of a stroke, if you have any of those, call 911. The idea is you'd actually have them practice that activity and with their families. It's kind of like when you learn CPR. If you practice on a simulator or a dummy, you get better than if somebody just tells you what to do. So we're looking at that. I'm actually really excited, and we think we can pick out high-risk patients from our TIA population and our prior stroke population. But we've got the infrastructure all ready to go, again, on this
You might
thing.
motivate people to prevent it from happening also, since this is practice of having it.
Yeah, I get nervous of whether they'll get overconfident and think, oh, I know what to do if I have a stroke so I can eat my cheeseburger and whatnot. But it's interesting, as we screen for lung cancer, are we going to see our smokers stop smoking, or are they going to just get screened? I don't know. So in any case, that's kind of what I'm talking about with the system. So as you launch something new, and let's say you don't have anything for hypertension, you can take any one of these functions and just plug it in. How are you going to apply these tools towards hypertension? Yes?
Dr. Kanter, can you speak a little bit about decision support regarding the EHR system?
Yes.
About the alert fatigue, whether the doctors are...
They don't get alert fatigue because I'm not sure they look at any of the alerts to begin with. But they actually, I think it's helpful. You got to be careful not to overdo it. The reason why this is actually in there, we have a whole department that creates decision support, and one of the keys, I think, is to measure the response rates. And so you can actually detect alert fatigue by seeing, do people blow through a specific alert. We did that with drug alerts, where our pharmacists got very enthusiastic, thinking they'll just prevent every drug reaction possible, and we loaded all of this stuff in there, and it got overridden, and then we realized we got to just focus on the real serious ones. So I think having some structure in place that can create support and then measure it is actually key. Otherwise, it's the loudest voice at the table gets their pet decision support put in. So I hope that answered your question. It is a definite real phenomenon. So Our proactive office encounter, part of our system, any department you walk into, they have a checklist that they'll go through. They'll measure your blood pressure, they'll measure your weight, they'll assess if you're smoking, how much exercise. I first started this with mammography and got our dermatologist to do mammograms. I would challenge anyone to go into a group of doctors, urologists, and say, all right, guys, I want you to start measuring blood pressure and see what happens. They do not take kindly to this without a large explanation of why this is important. And I think I have a slide. If you rely on primary care, you're missing a large portion of your patients. So here we'll focus on A1C testing, and the problem is we had 10,000 patients come into our system needing an A1C test over a certain period of time. Only 37% of them went to primary care. So if you want to get really high testing rates and you just measure things in primary care, you're already missing too many. And I suspect our system may be better than most in that people can't easily get to a specialist without a primary care referral. So I always wonder, well, how the heck does this happen? But it does. And these are the numbers, the same rates exactly with mammograms, which is interesting. And so 60% of your care gaps in cardiovascular disease will show up in specialty clinics. If you don't have a system to manage this, I think you're behind the 8 ball. So why is that important? We actually studied, again, blood pressures taken in specialty clinics. We measure control rates. We don't measure identification rates. To me, that's equally important, is how many hypertensives do you know about in your system? I don't know why HEDIS or somebody hasn't figured out a way to measure prevalence and risk adjust, but they don't. That's another one of my pet peeves. We found roughly 20% of our new hypertensive patients were first found in specialty clinic. Sizable portion to miss. A lot of these people had really high pressures, 14% or over 180. It's a little humbling. The good news is we found them. We actually, I think, started early on in dermatology. It's challenging for clinics with a high throughput, and they're seeing a large number of patients. But we did this. We had to back off. We don't measure every visit every time. If your blood pressure has been normal in the last 3 months, you get a pass in specialty clinic. How did we pick 3 months? We just made it up. But the bottom line is you need to be measuring in more than primary care. I think this is actually key for all of the cardiovascular diseases. Too many patients just don't go there. And well, we measure the control rate. It's on your rightcare stuff, and everybody gets excited about it. But let's say you have 200 hypertensives in your practice. If you only identify 100 of them and get them into perfect control, your control rate's 100%, but you've missed the other 100 people out there. Your real control rate's probably only 50%.